Hi, this is the first lecture in pediatric trauma, and we're going to speak about lower extremity. A good source that you can use is this book written by myself. So pelvic apophysis fracture, this is very common in adolescent. What is the apophysis? Apophysis is the epiphysis that is not involved in the joint and has muscle attached to it. Like calcaneal apophysis, for example, this is an apophysis because it's not in the joint and has the Achilles tendon attached to it. Another example is the tibial tubercle apophysis. This is an apophysis because it's not in the joint and has the patellar ligament attached to it. There are many pelvic apophysis that can get a avulsion fracture. The anterior inferior iliac spine, when it happens due to rectus femoris muscle avulsion, as you can see here. So this is the anterior inferior iliac spine, and it has avulsion fracture by pull from rectus femoris. Anterior superior iliac spine, it happens by sartorius avulsion. Ischial tuberosity avulsion, as you can see here, by hamstring. Sometimes the iliac crest can have an avulsion fracture, and it's happened due to pull of the abdominal muscle. The management of all these fractures is non-operative, symptomatic, so meaning rest and no sport participation till the pain resolve. Hip dislocation can occur in pediatric patient. As an adult, the posterior hip dislocation is more common. In the posterior dislocation, as you can see here, the limb will be adducted, as you can see in this X-ray. You see this is a pediatric patient, and because it's pediatric patient, there is physis. You can see the physis here, and the physis is here. You don't see it very clearly because of the position of the head, but when you do the reduction, it has to be a gentle reduction under complete muscle relaxation, because the worst thing that can happen is separation of the physis during reduction. It's called catastrophic complication. To avoid this, the child should be completely relaxed, and gentle reduction should be obtained. If closed reduction cannot be obtained, open reduction should be done. Also, if you do closed reduction and the joint is not concentric, that means that there is a possibility of a piece of bone inside the joint, and this needs to have open reduction. So dislocation of the hip, commonly posterior, the reduction has to be done gently because different than adult, there is a physis here, and if you pull too hard, you can do separation, which is catastrophic complication. So you need to do the reduction under complete muscle relaxation to achieve the reduction without excessive force. If reduction cannot be obtained, closed open reduction should be obtained. Proximal pediatric femur fracture, they are not common. However, it's an important topic because it may affect the blood supply. There will be separate lectures for the anatomy, but for a quick review here, the blood supply in children till the age of 4 years comes from both lateral and medial femoral circumflex. After 4 years, the medial femoral circumflex becomes more important. The Delbert classification of the proximal femoral fracture. This picture is from my book with Dr. Naga in Pediatric Orthopedic. Type 1, which happened through the growth plate. Type 2 happened through the neck. Type 3 is basal neck, and type 4 is intertrochanteric. And the more you go from type 1 to 4 is the less incidence of avascular necrosis. So this type has like a near 100% of avascular necrosis in the transepiphyseal one, and it's about 10% in the intertrochanteric fracture. One of the common complications that can happen is non-union and varus malunion, as we're going to see in this. One of the possible complications is a non-union and varus collapse. So this is type 2 fracture, transcervical fracture, treated with 3 cannulated screws. And then with time, you can see the varus collapse here. The neck is falling into varus with backing of the screws. The screws were removed, and CT shows obvious non-union here. And also you can see here the non-union. So other than the AVN, the other complication is non-union and varus collapse. So the treatment for pediatric proximal femoral fracture, as we said, it should be treated as urgent. because it may affect the blood supply. So it's either open or closed reduction. Most surgeons will do either capsulotomy or joint aspiration to relieve the hematoma and possibly decrease the incidence of osteonecrosis. And then the fixation, it's either screws that stops short to the physis, if you can do that. Sometimes you can, if the fracture is very proximal, you can put smooth pins across the physis, and then you can add that with a spica cast, or you can put plate and screws, as you see in this example here. So this is a basal neck, so this is type 3. It was treated with a plate and screws, pediatric proximal femoral plate. These are locking screws, and it has a stronger fixation. Sometimes the fracture proximal femur, like this one, is a trochanteric, and it's secondary to a simple bone cyst here. In these cases, because all this area here is pathological and there is basically no bone in this area, because all this is the simple bone cyst, we decided to use this method of fixation, and the screws cross the physis here, as you see, but then these screws should be removed as soon as healing occurs in like 2 or 3 months. After proximal femoral fracture, we're going to speak about pediatric femoral shaft fracture. This is a very important topic. It frequently comes in the exam. You should expect about 1 centimeter of overgrowth in most children between the age of 2 and 10-year-olds with femoral shaft fracture. Children less than 5-year-old are usually treated with immediate closed reduction and application of a spica cast. What does it mean, immediate? It means that you do not need to do pre-casting traction. Pre-casting traction was a common technique about 20 years ago, in which kids were admitted, traction was applied for a few days, and then after that the spica cast was applied. Currently we don't do this for children that are less than 5 years. We can just go for immediate closed reduction application of a spica cast. Two technical points in the spica cast: avoid the 90-90 degree cast that was common the cast before for fear of compartment syndrome. Currently we do mild flexion of the femur and mild flexion of the lower leg, so mild hip flexion and mild knee flexion, but we don't do the 90-90 cast because it can cause compartment syndrome. Also avoid the application of the lower leg cast and using it for traction. So these are the two technical points that you are sometimes asked about this in the exam. So again, for children less than 5-year-old, the treatment is immediate closed reduction and application of a spica cast. There is no need for traction for these kids. So for children less than 5 years old, you don't need to do pre-casting traction. For very young children, 6 months and less, the treatment can be by Pavlik harness. The harness that we use for the DDH, you can use that for children that are 6 months or less. You don't have to apply a spica cast. So this is the picture for the spica cast application using the spica table. So the child is put on the spica table, we apply the spica cast. As you see, we don't do the 90-90 anymore, and the cast should go all the way to the nipple here. You can see here the x-ray before treatment, and this is after application of the spica cast. In the next few slides, we're going to speak about the non-accidental trauma and its relation to femur fracture. I can assure to you that you will get at least 1 or 2 questions in your exam related to femur fracture and non-accidental trauma. The old name of the non-accidental trauma is the child abuse. So a few points that I would like to tell you about non-accidental trauma and femur fracture. It's not easy to recognize non-accidental trauma. You have to keep that diagnosis in your mind and actively look for it because most cases will not present easily as a cases of non-accidental trauma. 60% of the cases of the non-accidental trauma or child abuse present with an isolated long bone fracture. So this puts a responsibility on the pediatric orthopedic or the ER doctor to detect the non-accidental trauma that's presenting as isolated bone fractures. And remember that non-accidental trauma or child abuse actually happens to children of all ages, all socioeconomic background, So it is not limited to only one subset of family or one background. It can happen with all ages, all socioeconomic backgrounds. It's very important to keep that diagnosis in your mind when you see a patient with isolated long bone fracture, and of course if this bone is the femur, that also gives you an indication to think about this diagnosis. What are the risk factors of non-accidental trauma? Young parent, single parents, drug abusing parents, parents who were abused as a child, firstborn children, disabled children and premature children, and stepchildren and families of low income. So these are the risk factor of non-accidental trauma, but as we said, non-accidental trauma can happen in families of all socioeconomic backgrounds. But these are the risk factor for non-accidental trauma: young and single parents, young and single parents, parents who are drug abusing, parents who were abused as a children, firstborn children, premature infants, and disabled children, and stepchildren, and families of low income. Why it's important to detect non-accidental trauma? Because if you miss that diagnosis and the child goes home, there is a 25% risk of another serious injuries and 5% risk of death. So this is a very serious sequelae of missing this diagnosis. You have to get the patient into safe environment, and remember, abuse is the second leading cause of mortality in infants and children. So if you miss that diagnosis, the child goes home, there is a 25% risk of a serious injury and 5% risk of death. Now back to our topic of the femur fracture and its relation to non-accidental trauma. The most important red flag for the association between femur fracture and non-accidental trauma is the age of the child. So if you have a non-ambulatory child with a femur fracture, this is an indication that this may be a possible non-accidental trauma. So here, this is one of my patients, 9-month-old. He's not walking yet. He comes with a femur fracture. Bone survey shows also a clavicle fracture. So this is a case of non-accidental trauma. One word about spiral fracture, because people think that spiral fractures are accidental trauma for sure. There is a few things. There is two facts that remember that spiral fracture are actually more common in accidental trauma than non-accidental trauma, and only 1/3 of cases of non-accidental trauma are spiral fracture. So the fact that a fracture is a spiral does not really help you to differentiate between accidental and non-accidental trauma. If you get a scenario for a child 9 or 10-month-old with a femur fracture, always look for the answer that is discussing the possibility of non-accidental trauma. And if they give you multiple hints in the question that this is a case of non-accidental trauma, like the family are indifferent or aggressive, or they are coming 4 or 5 days after the injury, or X-ray shows another injury, all this is an indication that this is possible non-accidental trauma. So your treatment or the option that you want to choose in the question is get the Child Protective Service involved. What are the surgical options for pediatric femoral shaft fracture? There is basically 4 options: elastic nail, rigid nail, submuscular plating, and external fixator. We'll start with the flexible nails. These are one of the most common treatment for pediatric femoral shaft fracture. They are put usually in retrograde manner. It means that we go from the knee going proximally. The best indication and the classic indication for flexible nail is a transverse mid-shaft fracture with no comminution. Transverse because that will get good contact of the bone ends with no shortening. Mid-shaft because usually the flexible nail are not good treatment option for proximal or distal fraction, and no comminutions because you would like to avoid shortening, as the flexible nail is usually a weaker fixation than the other form of treatment, so you don't want to have comminution because it may cause deformity or shortening. Also, the child should be less than 100 pounds, which is about like 43 kilograms, because it was found that children over 100 pounds have more incidence of complication. So retrograde, flexible knee, best indication, transverse fracture, no comminution, mid shaft in a child less than 100 pounds. What to do to increase the stability of your fixation by flexible knee? The most important thing is the diameter of the nail. So if you're asked what is the most important parameter for stability using flexible nail, is the diameter of the nail. Always try to use 2 equal sized nail and contour the nail so that the spread of the nail is at the fracture side. What is the most common complication of flexible nail is irritation pain, irritation around the knee from the ends of the flexible nail. This usually resolved with the rod removal. So you may have a question, for example, 25 kilogram kid, he was treated with flexible nail. What is the most common complication? What do you tell the family? The most common complication will be irritation around the knee from the ends of the rod that will resolve with rod removal. You can see here X-ray, mid shaft, transverse fracture, a child less than 100 pounds. What is the method of treatment? Is flexible nail. You can get very good result, and it's a very small surgery. Usually you can do it in a relatively short time with very minimal bleeding. Now we finish the flexible nail. Let's go to a rigid nailing. Before we go into rigid nailing, I'd like to give a brief anatomy introduction. As we said, there will be a separate anatomy lecture, but this is just introduction for this topic. So we said that the blood supply to the neck of the femur comes from the medial and lateral circumflex, mainly, of course, after 4-year age, from the medial femoral circumflex. So if you go with the piriformis entry, which is in this spot, this is the piriformis. In children, you will come very close to the blood supply. So if you see here the medial circumflex, as we said, after 4-year-old, the medial circumflex femoral artery become the major blood supply. In kids, the piriformis entry is close to that medial circumflex artery, and using a piriformis entry can result in disruption of the blood supply and major consequence. Another option is to go here with which is trochanteric. It's a little bit safer. However, now for rigid nailing, we go into the lateral part of the trochanter, which is called lateral entry. This is a picture here. This is from the Synthes PDF for their nail. So this is the piriformis, this is the trochanteric entry, and this is the lateral entry. The lateral entry is in the lateral part of the greater trochanter. So it's not at the tip of the greater trochanter as the trochanteric entry. It is lateral part of the greater trochanter, and this is much safer, especially in kids, and it's away from the blood supply that comes here. So the rigid nail, so as we said, we don't use piriformis because it can risk avascular necrosis, because it can injure the branches of the medial femoral circumflex. Tip of the troch is a little bit safer. However, the lateral entry, which is here, is the safest. As you can see here, these nails are called adolescent nail, and all adolescent nail are lateral entry. So here is the fracture here in the femur. Child is more than 42 kilograms or 100 pounds, so flexible nail may not be the best. So the rigid nails, in this case, you don't go for trochanteric or piriformis, you go for the lateral entry nail to fix these fractures. After discussing a flexible nail and rigid nailing, third method is external fixator. External fixator used to be a popular method for fixation of a pediatric femur fracture. However, its use now is falling out of favor, mainly because of the high incidence of refracture. It's about 20% incidence of refracture, especially with the simple transverse fracture. So after removing the frame, there is a high incidence that the patient will refracture. The use of external fixator now is not as common as before. or the main indication is for open fracture or for unstable patient, like unstable polytrauma patient. This is an x-ray of an open fracture. You can see here the femur is outside the skin, so it's a grossly contaminated fracture. In the same time, this patient also has a tibial fracture, as we're going to see, so this is a very good indication for using external fixator. We applied here external fixator for fixation of this fracture. You can see here the flexible nail for the tibia. So this is a good indication. This is a polytrauma patient. Also, in the same time, it's an open, highly contaminated fracture. So external fixator, its use has been decreasing mainly because of the incidence of refracture. The refracture is highest with the simple transverse fracture. Submuscular plating also is the fixation method for pediatric femur fracture. It's used for comminuted fracture. We call it length unstable, especially proximal or distal. You can see here this fracture. It's a highly comminuted fracture. There is a big piece here, butterfly fragment. So if the method of fixation is not rigid, the fixation will fall into varus. Submuscular plating here was used for fixation of this fracture. The idea is to maintain the alignment and the length and the rotation, and then the fracture itself will heal with the secondary intention. This is another example for using the submuscular plating. You can see this is a 9-year-old girl was playing kickboxing. And she had a fracture femur. If you see this fracture here is very proximal. There is an extension here that goes all the way to the lesser troch. So this is not a good indication to use a flexible nail, because the amount of fixation proximal to the fracture will be minimal. So submuscular plating was used for this patient. If you can see here, a plate was introduced through the whole length of the femur with 3 screws above the fracture and 3 screws distal to the fracture, maintaining the alignment, length, and rotation, and then you get secondary healing at the site of the fracture. So in summary, for infants less than 6 months, we use Pavlik harness. From 6 months to 4 years, immediate casting, no need for pre-casting traction. And then from 5 to 12 years, if the fracture is comminuted, submuscular plating may be the best option. If it's a non-comminuted transverse midshaft fracture and the child is less than 100 pounds, flexible nail is a good method of fixation. For children older than 12-year-old, lateral entry rigid nail may be the best method for fixation. So this is a good summary to have. First 6 months Pavlik harness, from 6 to 4 years immediate casting, from 5 to 12 if it's comminuted submuscular plane, if it's submuscular plate. If it's not comminuted and the child is less than 45 kilos, flexible nail is a good option. Older children or heavier children, lateral entry nail is a good option. Now we talked about the proximal femur and the shaft femur. The next topic is the distal femur physeal injury or the Salter-Harris injury. The distal femur physis has a certain characteristic, that it has like process inside the epiphysis. It's called mammillary bodies. So it interdigitate with the distal femoral epiphysis. So when you get injury, rather than having this injury in one layer, this layer, as we said in the basic sign lecture, if you go to the one that talks about the growth plate, we said that the injury that happened through the growth plate in general happened through the zone of hypertrophy, or to be more specific, into the zone of calcification into that part of the zone of hypertrophy. So the other zones are left intact, and they, in most cases, there is no injury to the growth plate. That doesn't happen in the distal femur injury because it goes through multiple layers. As we said, the distal femur physis is not a straight line. There is lots of interdigitations called mammillary bodies. That's why the injury goes through multiple layers, and that's why the distal femur physeal injury has the highest incidence of growth disturbance. It's up to 50%. Another thing you need to know that these injuries come close to the popliteal vessel, so they may have cause injury to the popliteal vessel. So distal femur physeal injury, they can injure the popliteal vessel, so you need to do urgent reduction. You shouldn't be leaving it for a long time. And then the growth plate of the distal femur is not a straight line. There is prominence called mammillary bodies. It interdigitate with the distal physis. The injury that happens does not go through one layer, which is the zone of hypertrophy, and the part that is in the zone of hypertrophy is the zone of calcification. It occurs through multiple layers, and that's why it's more prone to get growth disturbance. It's the highest growth disturbance among all growth plates, up to 50%. One thing characteristic in the imaging of the distal femur, that sometimes the x-rays are normal, as you can see in this x-ray. And if you have a high suspicious of this is a physeal injury, there is a marked tenderness, the patient cannot put weight, and most of the tendon is over the bone, you can either get a stress view or get an MRI. So this patient, because of the high suspicious, an MRI was ordered, and you can see here the MRI show clearly the injury here into the epiphysis, and you can see it here. It's a type 3, so it goes through the growth plate here and then grow inside. So it's a type 3 Salter-Harris, and the x-rays that was taken 2 weeks post-op shows the injury and shows the healing here. Imaging in the distal femur physeal injury can be negative in the beginning. So if you have a high suspicious, you can either order an MRI or get a stress view. The fixation method for the Salter-Harris injury depend on the type of the injury. So if you see this example is a Salter-Harris type 2 with relatively big metaphyseal fragments. So these can be fixed using screws parallel to the physis without having to cross the physis. As you can see here, this is Salter-Harris type 2. Fixation here was done with 6-5 cannulated screws parallel to the physis without having to cross the physis. In Salter-Harris type 1, as you can see in this example, the treatment is usually crossed smooth wire. You may get a scenario in your exam talking about diminished vessels, so the treatment will be urgent reduction and fixation. Try to stay away from invasive studies like invasive angiogram, as this may delay the treatment. The treatment should be urgent reduction and fixation, and then reassessment of the pulse. As we said, the gross disturbance after Salter-Harris injury of the distal femur is common, about 50%. It may result in limb length discrepancy, or it may result in deformity. So it is one of the most common, or the most common growth disturbance from a physeal injury is the distal femur. So this is another example. This is Salter-Harris type 2 distal femur. However, in this example, as you can see here and here, the metaphyseal segment is much smaller, so you cannot really use it for your fixation that is parallel to the physis. It's very small parts. It won't hold the strong fixation. So this type can be treated like similar to type 1 with crossing K-wire, as you can see here in this example. The difference here is that after putting the screws from distal to proximal, we kept pushing after putting the wires, we kept pushing the wires till they came out of the skin, and then they were pulled out proximally so that the wires are not left intra-articular. And we use this technique so that if you get a pin tract infection, it does not travel across the wire to become septic arthritis. So here's Salter-Harris type 2, small metaphyseal segment treated with crossing smooth wires going from distal to proximal, and then after crossing the cortex, the wires were kept going all the way till they came out of the skin, and then they were pulled proximally so that the wires are not intra-articular to avoid having septic arthritis if the patient develops severe pin tract infection. You can see here the pins here coming proximally. You can see this picture here. This is from my book. This is one of my patients. She had a distal femur physeal injury a few years ago. So she's presenting with 5 centimeter limb length discrepancy. So lengthening was done using monorail to gain that 5 centimeter difference that the patient has. So the distal femur physeal injury is very prone to growth disturbance, about 50%. The growth disturbance may be deformity or limb length discrepancy. Now let's go to another bone, the patella. One of the common topic to be asked is the sleeve fracture of the patella. So the sleeve fracture, as you can see, this picture is from my book. This is the calcified part of the patella. You will find a small piece here distal, and then the main piece is pulled proximal, so the patella will be patella alta. However, this small piece has relatively large piece that is non-calcified, so it is radiolucent in the X-ray. With the exam, the patient will not be able to extend the knee. There will be a loss of the extension power because the extensor mechanism is disturbed, and the treatment for this is not excision. You may say, oh, it's a small piece, we'll do excision. No, it's relatively big piece because there is a big piece of uncalcified part of the patella here, so the treatment is open reduction and internal fixation. So this is called the sleeve fracture of the patella. It's a small piece here of the patella. However, it has a relatively large segment of uncalcified radiolucent part of the patella. The treatment will be open reduction and internal fixation. Now we'll start the pediatric tibia fracture. The first topic in the pediatric tibia is the tibial spine or the tibial eminence fracture. And there are three types of the tibial eminence fracture. Type 1, which is incomplete or non-displaced, as you can see here. Type 2, which is angulated but not displaced. It's hinging on the posterior part, so it opens anteriorly like this. And type 3, which is angulated and displaced. This injury actually represents some form of an ACL avulsion, because you know the ACL is attached to this area here, and type 3 can be associated with the medial meniscus, anterior horn of the medial meniscus entrapped under the fracture. So if they give you a scenario for a type 3 that cannot be reduced and ask you what is the cause of the surgeon not able to reduce the fracture, is the entrapment of the anterior horn of the medial meniscus. So it's the anterior horn of the medial meniscus. It's not the lateral meniscus. So anterior horn of the medial meniscus can be entrapped in type 3. The treatment for type 2 is usually closed reduction and cast extension in casting. If this fails, you can do open or arthroscopic reduction. However, most cases of type 2 can be treated with closed reduction and cast in extension. Usually once you put the limb in extension or a little bit degree of hyperextension, this anterior opening will close, and then you can cast the patient. Type 3 is the one that needs reduction, either open or arthroscopic, and the method of fixation is going to be either sutures or you can put screws. However, the screw has to stop before the physis. So it's called intraepiphyseal screws. The most common complication of surgical treatment is stiffness and arthrofibrosis. This is very common after surgery, or the most common complication is the stiffness arthrofibrosis, and it is related to the time of the surgery. So they may ask you what is the most important indicator of the fibrosis after surgery. Is the duration of the surgery. The more you do the surgery, the more chance that you will get complication, and it's understandable. That means that the case was harder, so this is maybe associated with higher incidence of stiffness and fibrosis. And usually even with treatment there will be some asymptomatic laxity of the anterior cruciate ligament, because the theory around that is most probably before the avulsion happened, there is some stretching that happened to the ACL at the time of the surgery. So the second topic after tibial eminence is the tibial tubercle avulsion. The tibial tubercle avulsion usually occurs in adolescent near their maturity. The shape of the tibial proximal tibia is usually looks like this. So the growth plate here will be going distally, anteriorly. The tibial tubercle is that part here of the apophysis that is attached to the patellar tendon. Type 1 is the avulsion of this part only without going proximal. Type 2 has proximal extension but does not go intra-articular. Type 3 will go intra-articular. Sometimes type 3 may get meniscal injury. Again, as this injury usually happen at close to the time of the closure. Usually the mechanism is jumping, like during playing basketball, for example. The most common complication is it can cause injury to the anterior tibial recurrent artery, which can cause hematoma, and this hematoma can cause compartment syndrome. If this happens, of course, the treatment is fasciotomy. The treatment of the condition in general is open reduction, internal fixation. You don't do closed reduction for these cases because you cannot really push the piece back because there is the extensor mechanism is attached to it. The second thing is the periosteum is usually flipped into the fracture, so you need to do open reduction, get the periosteum out, and then fix with the screws. The screw will cross this part of the physis. Usually this is does not cause problem because these kids, as we said, are very close to ending their growth. So usually there is no growth disturbance with these screws. If that happens into a child that you think has more growth than usual, you can remove the screws once healing is achieved. Here is another example. This is type 3. It goes intra-articular. So these are two pieces of the tibial tubercle that are here. So open reduction is obtained, as you can see here, and then this is fixed with two screws here. So the treatment is open reduction, internal fixation, fixation with the screws. The screw will cross this part, so this is a part of the growth plate. If you see here, the child already stopped the growing here, so this part, if you put the screw across it, it should not cause deformity. Here is another example. Tibial tubercle avulsion. This is type 1, so you think it's a small injury. You can see the growth plate here are coming very close to the closure. However, you can see the clinical picture is the huge swelling that this child has. This actual child had an impending compartment syndrome. He was in severe pain in all that proximal part of the lower leg, and you can compare here the size of this left side compared to the right side. Next topic in the tibia is the proximal tibial physeal injury. I know that some people are confused between the difference of the tibial physeal injury and the tibial tubercle avulsion. Tibial tubercle avulsion, as we said, it's the part that is attached to the patellar tendon. In the proximal tibial physeal injury, the injury will go all the way posterior. It will not have a coronal fracture here that separate the piece that is avulsed from the proximal tibia. Proximal tibial physeal injury are usually type 1 or type 2, so the injury will either go through the physis or it will take part of the posterior metaphysis. It can also have vessel injury or compartment syndrome. The common one that will get to compartment syndrome is actually the extension type. So the common fracture is the flexion type. The extension type, if it happens, it may injure the popliteal vessel because the popliteal vessels are tethered by the posterior surface of the tibial epiphysis. The X-ray, as we said in the distal femur fracture, the primary X-ray may be normal. If you have a high suspicious, you can get an MRI or stress view, very similar to the distal femur physeal injury. The treatment is reduction. You can do closed reduction or open reduction. If remember when we said the tibial tubercle usually requires open reduction. The proximal tibial physis can be reduced, in most cases closed. If you cannot, you will have to do open reduction, and the treatment is either screws across the physis if you think that the remaining growth is minimal, or you can use smooth wires across the physis if you think that there is a relatively long time of growth, and then you can remove the physis. Then you can remove the K wires later on. So you can see here this is flexion type injury, which is the most common type. The injury goes through the growth plate, and then you can get here a metaphyseal part. The closed reduction was obtained and screws fixation was done. Here another example here. Again, this is a fracture type, flexion type 2 of the proximal tibia. So this is not tibial tubercle. The tibial tubercle will be, the injury will be associated with a coronal fracture here. but in this one the injury went all the way posteriorly and then it took part of the metaphysis. So this is a proximal tibial physeal injury and not tibial tubercle avulsion. Here is the AP. This one was close reduced and fixed with two smooth wire across the physis. You see here that there is relatively remaining part of the physis, so we didn't want to put screws across the physis in this one, and we prefer to put a smooth pins. After finishing the proximal tibial physeal injury, the next fracture is the proximal tibial metaphyseal fracture. So if you see this fracture here, it's not at the level of the physis, it's in the level of the proximal metaphysis. And this fracture has a very specific characteristic of it, that even if it's a non-displaced or minimally displaced, it can develop with time some sort of a valgus deformity, as you can see here, associated with overgrowth. The reason for this valgus deformity is theory behind it. It's asymmetrical growth of the proximal tibia, with more growth coming from the medial side, resulting in the valgus deformity. This is called Cousin fracture. So usually this is called Cousin fracture, and the treatment for this condition is observation, because in most cases the child will improve with time. If with observation the condition is not improvement, you can go for guided growth, meaning that you put either stable or a guided growth plate here, allowing correction of the valgus deformity. So proximal tibial metaphysis, usually the fracture will heal with no problem. Sometimes you will get what's called as Cousin fracture or Cousin phenomena, in which the child with time will develop valgus deformity, as you can see here in this x-ray. This is a follow-up for this x-ray. What happens is that there is asymmetrical growth of the proximal tibia, with more growth medially, resulting in valgus deformity. Treatment is observation. Most of these cases will improve with time. If it does not improve with time, you can proceed with guided growth here on the proximal medial side. So next thing in the tibia is what's called toddler fracture. Toddler fracture, it's a spiral fracture due to twisting injury of the tibia with an intact fibula. As its name applies, it happens in toddlers, so usually kids around the age of 2 to 3 years old. And usually there is no history of obvious trauma. Usually the mother will come and says that the child was playing with his brother, and then all of a sudden he's crying and he doesn't want to put full weight on the affected side. Remember, the fibula is intact, so the children in these cases may be putting some weight, or they can stand a little bit, but they won't be able to walk normally. X-rays, sometimes the X-ray will show a spiral fracture. You can see here that non-displaced incomplete spiral fracture. Sometimes it's completely normal and you can't see anything, and all what you see is the X-rays after 2 weeks. You will see the periosteal reaction indicating the healing. The treatment for all these cases is above knee cast. Tibial shaft fracture, this is a common fracture in children and adolescents. It's associated with major soft tissue injury, so it can be associated with compartment syndrome. So if you notice in the question that they are telling you the pain is getting worse, patient pain cannot be controlled with any narcotics, this is a hint that the patient is developing compartment syndrome and he needs fasciotomy. Most pediatric tibial shaft fracture can be treated with closed reduction and long leg cast application. If for any reason you choose operative treatment, most of the time it's either plate and screws or flexible nail. If the child is still not skeletally mature, you cannot use rigid nail because you may injure the physis proximally. If it's an open fracture, external fixator can, in most cases, is the preferred treatment. Like this patient, he has a minimally displaced tibial fracture but major soft tissue injury. The method of treatment in this case was external fixator. Now we'll start the topic of ankle fracture and distal tibial fracture in children. The incidence of growth arrest in these cases is high, can reach up to 50%. The treatment for type 1 and type 2 is usually closed reduction and casting. If there is failure of closed reduction, you can proceed to open reduction. Usually the reason is entrapped preosteum. However, open reduction was not found to decrease the incidence of growth disturbance. Type 3 and type 4 needs open reduction internal fixation. In type 3, you will pass the screw in the epiphysis. You can see here type 3, open reduction was done. 2 screws were introduced into the epiphysis parallel to the physis. If it's type 4 and there is adequate metaphysis, you can use that part. Type 4 medial side has the highest incidence of growth arrest, and when growth stops from the medial side, it will result in varus deformity. So this X-ray is from my book for one of my patients. So this is a Salter-Harris type 2 of the distal tibia. You can see a large metaphyseal part here. So the treatment for this is closed reduction and cast application. Most of the Salter-Harris injuries of the distal tibia can be treated with closed reduction and casting. So this is a Salter-Harris type 2. There was failure to obtain adequate closed reduction. Usually the reason is the preosteum here entrapped in this area, and you cannot bring it back into position. So open reduction was done, the preosteum was removed, and 2 smooth wire were introduced across the physis. There is 2 characteristic fracture that happens in the tibia, the triplane and the T-low fracture, and we're going to discuss both. There is an important anatomical fact here in the distal tibial physis. It does not close as one line in the same time. It takes about 1 to 1.5 years to close. It follows a certain pattern, usually starts central, then go posterior, medial, and lateral. So the lateral part is the last part to fuse. So you can see here in certain fractures you will get a avulsion of the lateral part if this is the only part that did not fuse yet. And this is called the pediatric T-low, as we're going to see. The triplane and the T-low fractures happens during this period of the closure. So avoiding the growth disturbance is not the major goal. The major goal in this fracture is getting the anatomical reduction, because these are intra-articular fracture. Remember that T-low fragment, as in the adult, has the attachment of the anterior tibiofibular ligament. We can see here, this is the CT of the patient that we saw in the previous slide. Here is the T-low fragment. As we said, the growth starts central and then go posterior and then medial and then lateral. So the lateral part is that last part to fuse, and you can get that here, the pediatric T-low. So these fractures can be treated with a screw. You don't have to avoid the physis. You can go across the physis because the physis basically had stopped growth. So this is the pediatric T-low, and this is the treatment is open reduction internal fixation. This is the triplane. The triplane fracture is called triplane because it happens in the coronal and the sagittal plane. So this is 3D, so we can understand better. You can see here there is this line of the fracture here, and if you go, there is a more coronal here. So there is a sagittal fracture here, and in the back there is a coronal fracture. So it's in triplane fracture. And you can see here the picture from the medial. You can see the coronal line here, and you can see the sagittal line here. So this fracture also is treated with open reduction internal fixation. The main goal is to get articular reduction. So remember that for foot fracture, the most common metatarsal fracture in young kids is the first metatarsal. Here you frequently get children who fell down or have something fall on them, and they have swollen foot. The x-rays will show fracture of the first metatarsal close to the base here. So this is the most common fracture of the metatarsal in young kids. Thank you for listening to the lecture, and I hope you found it useful for you. Thanks.